Hello everyone. This is part 2 of our audio and video of hematology. So if you're following along with me in your book, we're at about the middle of page 77, the hematology lab. Some of the illnesses that the hematology lab helps a physician to diagnose are things like anemias, leukemias, and infections. Anemias are where there aren't enough numbers, there aren't enough red blood cells, so the numbers or the normal range is decreased. So maybe we don't have enough, maybe we've been bleeding. Or you know that these are made in the bone marrow. Maybe the bone marrow isn't making enough. So maybe the doctor has to look for signs of bleeding, or he or she has to look for problems in the bone marrow. In addition, there can be not enough hemoglobin within the red blood cell. Maybe there's enough red blood cells but not enough hemoglobin inside. You remember from part 1, I said hemoglobin is a very large molecule, partly made up of iron. So maybe we're not eating enough iron in our diet, or maybe we are eating enough iron in our diet, but our stomach and our intestine isn't able to absorb it. Or maybe our liver isn't able to metabolize it. Maybe our spleen is destroying the red blood cells. So there's all different types of problems that the hematology lab can help the physician to diagnose in terms of red blood cells. In terms of white blood cells, we have leukemias, and these are malignancies of the bone marrow. In part 1, we talked about the 5 different types of white blood cells. There can be a malignancy in each one of those cell lines. Remember the neutrophil or the lymphocyte or the eosinophil. We can have different types of cell lines in the bone marrow, and there can be a cancer or a malignancy in those, and then that type of leukemia has a different mode of treatment. So again, we help the physician in the hematology lab by discovering which type of cell is abnormal. As well, infection. So this would be the more common type of thing where our white blood cells are infection fighters. So when we have some increased white blood cell count, sometimes we think about infection. This would be somewhat increased, and of course the leukemia would be way high increase. These would be both be increase in white blood cell, and the anemia would be a decrease in the red blood cell or a decrease in the hemoglobin. The hematology lab also helps with the diagnosis of coagulation problems. This centers around a process called hemostasis, which is the balance in the body where we form a clot or we stop forming a clot. So if we cut our finger, we don't want our finger to go on bleeding forever. We want the body to be able to form the clot and then heal. But we don't want to form a clot when a clot doesn't need to happen, like in a stroke or a heart attack. So we have that delicate balance between bleeding and clotting. And the hematology lab performs tests that determine whether the patient has the correct balance. Especially if the patient has had a clotting disorder like a stroke or a heart attack, the patient may be on medications to prevent those from happening again. Those medications interfere with the process of hemostasis, and so we may do blood tests to monitor that the drug is working. Other hematology tests, moving down the page here, and looking over at page 78, excuse me, at the bottom, hematology testing. metabolic disorders, nutritional, immunologic, and neoplastic. Let me talk a few minutes about those. Let me just say, excuse me, the chart that you see above the hematology testing on page 78, you don't need to worry about that. That's just showing you different prefixes and symbols and what they mean in terms of decimals. You don't need to worry about that. Let's talk a little bit about other metabolic disorders. I briefly mentioned these. Uh, Maybe we're getting enough iron, but our body's not absorbing it. Or maybe we have a poor diet, we're not getting enough iron or folic acid or vitamin B12. Those will cause anemias. Okay, immunologic disorders, an infection will cause an elevated white blood count, and then a neoplastic disorder such as leukemia will cause a way, way high white blood count. So again, the hematology lab helps the physician to diagnose all of that. On the top of page 79, who can perform tests? So the medical assistant we've talked about in, excuse me, in Unit 1 we talked about CLIA wave tests. So the medical assistant can perform only CLIA wave tests in hematology. These CLIA wave tests can be erythrocyte sedimentation rate, sometimes called a SED rate, sometimes called an ESR, a spun microhematocrit, and a hemoglobin. We will do the ESR and we will do the hemoglobin in our laboratory. Also the prothrombin time, that is a coagulation test. There are certain types of prothrombin time methodologies that are not CLIA waived and others that are. So you would have to know which ones are available in your office where you're working, which ones can be performed by a medical assistant. Moving down here to the complete blood count, and we're moving down now to the bottom of page 79. What all does a complete blood count include? We don't usually say this term complete blood count, we just say CBC. It consists of a total white blood cell count, a total red blood cell count, a hemoglobin determination, how much hemoglobin is in the average red blood cell. The hematocrit. What does hematocrit mean? You remember seeing the picture in part 1 of the red blood cells at the bottom of a tube, and then that buffy coat, and then the plasma at the top. So for any given portion of blood, however much is collected, or in the whole body, whether we're talking about a sample of blood in a tube or in the whole body, how much of the blood is red blood cell and how much is the plasma. So we report hematocrit in a percentage. So for however many milliliters of blood we collect, what percentage of that total volume of milliliters is red blood cell? That would be the hematocrit determination. Then we have something called indices. There are 3 indices. If we only had one, it would be called an index, but more than one index are called indices. These are 3 different indices, and they are calculations. You would never have to calculate these. These calculations are done in an automated instrument. And to do the calculation, the instrument has to do the red blood cell count, the hemoglobin, and the hematocrit. So it does those 3 tests and then it performs these calculations. The calculations help a physician to, excuse me, to determine what kind of anemia. We talked about metabolic anemias, nutritional disorders. There are other types of leukemias I'm sorry, there are other types of anemias, and these indices help the physician to determine which type it is. We really need to know which type it is because the treatments for the different ones are different. So we don't want to get the wrong treatment because we've diagnosed it incorrectly. To do a complete blood count or a CBC, we need anticoagulated blood. That means blood that has not clotted. We need a lavender or purple or EDTA tube. When someone says, please collect a lavender, or please collect a purple, or please collect an EDTA, those are all synonymous terms, and the blood will not clot. We can draw it from a venipuncture. We can draw it from a finger puncture. So we must see intact cells. We must be able to look at them under the microscope. We must be able to count them. So this blood cannot clot, and it has to come from the lavender or purple or EDTA tube. At the bottom of page 80, you see an automated cell counter that would be found in a small office situation. Excuse me. One thing that you see on the top, on the bottom of page 81, your book talks about aerosol safety. I don't have that in the notes. It goes over to page 82, and it talks about the different types of caps on tubes and how you open them. The older tubes have rubber tops where when the cap was removed, the person who was opening them could be exposed to aerosol, and within that aerosol could be an infectious organism. And so the type of tube that you see on the bottom of page 82 is a HemoGuard, and that prevents the aerosols from escaping and from you as the technician opening them from getting exposed. So that is not in this note page. On page 82, your book starts to talk about the 5 different types of white blood cells. You can see them in the bullet points there. And we're going to take a look now at those, even though I talked about those in part 1. We'll briefly talk about that now. First, we do a complete white blood count. Remember in part 1 we talked about normal ranges for each lab test. The normal range for the total white blood cell count is 4,500 to 11,000 per cubic millimeter. So what does that mean to you? Well, in everyday language, if you think about a teaspoon, the average teaspoon is about 5 cubic millimeters. So let's just take a round number in between here. Let's just say 10,000 per cubic millimeter. So if the average teaspoon then would contain about on the average of 50,000 white blood cells per teaspoon. So to put that in an everyday perspective. So we do the total white blood cell count, and then we look at each of those 5 different types. I'm going to come back to talk about those, but I want to talk about these 2 terms, leukopenia and leukocytosis first. Leukopenia means a decreased number, so there aren't enough white blood cells. Leukocytosis means there are too many. And then leukemia would be the actual malignancy. Okay, so we're going to talk again about the 5 different types. I talked to you about them in part 1, but we're going to briefly go over them again. I'm going to take you back out to the web and show you Here is the neutrophil. These are the most plentiful, somewhere around 50 to 70%. This reference says 40 to 75. These are the most plentiful, and what they do is they envelop a foreign invader and then they kind of eat it and digest it, spit it out where it's no longer, it can no longer cause harm. So this is the poly or the seg or the neutrophil. The granules are a neutral color, and you can see the segmentation of the nucleus. Again, you see the red blood cells are the erythrocytes, and here you see a platelet. This is the adult form, and this is the band. This is the same cell when it was a little bit younger, a little bit more immature. It didn't get its segmentations yet. This is only about 1 to 3%, so if we see this increased, we know that there is an infection because the bone marrow is putting these out too early. So this is our body's, an increased number of these would be our body's signal that we're fighting an infection. The next one would be lymphocyte, and if you're following along in your book, we are now on page, the top of page 85. These are smaller and the nucleus is very tight. There's a wee little bitty amount of cytoplasm. Again, you see the red blood cells and the platelets, and this cell makes antibodies and it tries to fight viruses. It knows when a foreign invader is around and it sends signals to other cells and it makes antibodies. So measles, mumps, rubella, things that have been in the news lately, this cell is what helps us to make antibodies to fight off those viruses. The next one is a monocyte. This is the largest white blood cell. Look at the difference between the sizes there. This is a large white blood cell. The nucleus is not near as tight as the lymphocyte. It looks like a kidney bean or a horseshoe. And out here in the very light colored cytoplasm are holes that we call vacuoles. This cell envelops invaders and eats them and digests them and spits them out, similar to what the neutrophil does. This is the eosinophil, moving down to the bottom of page 85, and this is the cousin of the segmented neutrophil. Here you saw the segmentations, but the granules were a neutral color, where this is a segmented neutrophil, but the granules are a dark pink or red, or sometimes they even stain an orange color, depending on the nature of the stain. So this is a segmented neutrophil, but the granules are different, and we think this fights allergies. So when this is elevated, it fights allergies. It's only about 1 to 4, maybe even 1 to 3% of every 100 that we count. And last but not least, this is a basophil. Again, this is a cousin of the eosinophil and the segmented neutrophil. They're all three the same nucleus with the segmentation. It's just that the colors of the granules are different. The granules are so dark purple or black sometimes, even looking, that it's hard to even see the segmented nucleus. You may not see these. Even if you count 100 white blood cells, you may not even see one of them. So that usually it's 0 to 1% is normal. We think that these are prevalent when there is an anaphylactic, some sort of a skin reaction going on. What you will be doing in the lab is making, you will be putting a drop of blood onto a slide and then smearing the drop along the slide, and you will be trying to achieve a feathered edge. The difference between these two slides here is that this is just the drop of blood that's been dragged along, smeared along. This is that slide when it's been stained. We will put it through a stain so that we can then look at it under the microscope to see the cells like this that I've been showing you. So that is the end of part 2, and we're now at the top of page 87, and part 3 will start in the middle of page 87. Thanks very much for hanging with me.